Welcome! Let's begin. We have a case for you today.
Doctor, a 68-year-old smoker presents to the emergency department. He has a 6-hour history of sudden, severe pain in his left leg. How do you proceed?
Okay, thank you. With a presentation like this, a systematic approach is absolutely crucial. I would structure my assessment by first taking a thorough history, followed by a detailed physical examination. Then I would order key investigations to help formulate a diagnosis and determine the underlying etiology.
So starting with the history, my first priority is to really unpack the chief complaint, which is, of course, the severe leg pain.
I'd really interrogate the pain itself. When exactly did it start? How long has it been going on? Where is it located? How severe is it on a scale of 1 to 10? Has it been getting progressively worse? And are there any aggravating or relieving factors? Getting these details is key.
Okay. And beyond the pain itself, what other associated symptoms would you specifically ask about? What are the real red flags here?
The critical symptoms I'd be looking for include any pain at rest, numbness or that pins and needles sensation, a feeling of coldness in the limb, and, most urgently, any signs of paralysis or weakness. Then I'd explore the high-yield risk factors. I need to know about his smoking history, any diagnosis of diabetes or hypertension, and especially any known cardiac disease like a past heart attack or atrial fibrillation. A history of high cholesterol or any prior vascular interventions is also vital information.
Good. You've taken a thorough history. Now walk me through your physical examination. For the physical exam, I would follow a systematic approach. Inspection, then palpation, and any necessary special tests. And the absolute key here is to constantly compare the affected leg with the contralateral, or good, leg.
On inspection, I'm looking for any telltale signs. You can learn so much just by looking. I'm checking for pallor, loss of hair, shiny skin, or changes in the nails, which often suggest chronic poor blood flow. I'm also looking for any ulcers or fissures, and of course, any acute discoloration that might signal a more recent severe problem.
Next is palpation, and this is critical. I would systematically assess the pulses, starting with the femoral artery in the groin, then the popliteal behind the knee, and down to the pulses in the foot. The level where the pulses disappear gives me a pretty good clue about the location of the occlusion.
And I just have to emphasize again that point about comparing the two limbs. It is so important because the patient's normal leg acts as their own built-in control. Any difference in temperature, color, or pulse strength becomes immediately and highly significant.
All right, your history and examination are strongly suggestive. Let's move on. What investigations would you order to confirm your suspicions?
For investigations, I'd start with essential blood tests, a full blood count, coagulation screen, and renal function tests. At the bedside, a handheld Doppler is a quick and easy way to confirm if the pulses I couldn't feel are truly absent. Next, to quantify the ischemia, I would perform an ankle-brachial pressure index, or ABPI. And finally, for definitive imaging to plan our treatment, we need a duplex ultrasound or, more likely in this acute setting, a CT angiogram.
Okay, so you get the ABPI back. In his left leg, it's 0.4. Tell me, what is the significance of that finding?
An ABPI of 0.4 is extremely significant. A normal value is generally considered to be above 0.9. A value below 0.5, like this one, indicates severe peripheral arterial disease. It provides objective evidence that there is a critical lack of blood flow to that limb.
There's an important pitfall to be aware of with the ABPI. Sometimes you can get a falsely high reading, something over 1.2. This often happens in patients, particularly those with long-standing diabetes, whose arteries are calcified and rigid, making them hard to compress. So you always have to interpret the number within the full clinical context.
Okay, so putting it all together, the history, the exam, the investigations, what is your diagnosis, doctor?
Given the acute onset of severe symptoms, the physical findings of ischemia, and that critically low ABPI of 0.4, the diagnosis is acute limb ischemia. This is a true surgical emergency, defined by a sudden drop in blood flow that directly threatens the survival of the limb.
That's correct. Now, let's talk etiology. What are the most common causes of acute limb ischemia? The most common cause is an embolism. That's where a clot from somewhere else, usually the heart in a patient with atrial fibrillation or after a heart attack, travels downstream and gets lodged in an artery. The other main cause is thrombosis, where a clot forms right on site in an already diseased and narrowed vessel. Less commonly, it can be caused by trauma.
Excellent. So you've correctly diagnosed acute limb ischemia.
As you said, this is an emergency. The clock is ticking. What is the next absolutely crucial limb-saving step?